Hello, everyone. Welcome to this presentation. So today we are going to have a talk about the longer stay patient. And I'd like to look at information regarding practices that can reduce ICU length of stay. My name is Lameck, Semwogerere. I am a consultant intensivist. I work with the Uganda Heart Institute, and also I'm a lecturer at Makerere University College of Health Sciences in the Department of Anesthesia. You are all welcome, and please share with me what you know as I share what I've gathered for you. And at the end of the session, questions will be welcome as we discuss this topic that is really challenging all over the world. So when we talk about a longer stay patient, what exactly do we mean? Some of you may know, internationally, we are challenged when we admit patients to the intensive care unit. We really want them to get out of this center as soon as possible. But you remember they come with different conditions, which have different severities. We have different setups of critical care units all over the world. We have different guidelines locally and internationally. So all these factors have a role to play when it comes to how long your patient will spend in ICU. So it brings me to a question: how do we know? Why should we bother about the length of stay in the intensive care unit? Because I mean, patients come to the hospital to be treated, so we should probably keep them for as long as they get better. But that's not the case. We are always struggling to ensure that these patients don't stay very long in the critical care units as well as in the hospitals. So one will ask, why bother? Remember, for critical care admissions, you require multidisciplinary skilled personnel. You need sophisticated equipment. We need multiple interventions to be done on these patients. And of course, these come with a very high cost of healthcare. And of course, also they consume a lot of time, a lot of consumables required, and money. So the expenditure is really high. So for us to be able to minimize the cost of healthcare and also reduce on the time and everything that we spend on these patients, we need to optimize their stay and make sure that they stay for the shortest period possible. And also, it is important to remember that because we don't have so many critical care beds all over the world, more so in Africa and in Uganda, we have very few beds. It is very important that we minimize the length of stay so that we can avail these beds for the other patients who may need them. As you may all know, before I even look at the risk factors for patients who stay for a long time in the unit, it is important for us to know, do we even know what exactly prolonged stay is or longer stay is? Given the differences in the type of patients we admit and also the severity of illness, the locations, the different protocols and guidelines, practices in different regions, there's no universally acceptable definition of prolonged length of stay. However, different studies quote different length of stay depending on the type of the unit and the type of resources they have. So you will find that the definition of length of stay will vary depending on where you are and depending on the nature or the type of the ICU that we are talking about. Some people have quoted beyond 7 days, others beyond 21 days, depending on the medical patients who spend really a lot of time. Surgical patients generally spend a short time. So depending on which kind of the category of patients, the definition may vary. So let's look at a few risk factors for increased length of stay. As you may know, the indication for admission, patients who come in with a polytrauma, sepsis, maybe post-cardiac arrest patients. Then, of course, we have patients with neurological conditions, patients with neuromuscular diseases. These are patients from the word go. they are at a very high risk of increased length of stay if we don't manage them in a very optimized manner. Of course, we have interventions needed. Patients who require invasive mechanical ventilation tended to stay longer, mostly depending on the cause of the respiratory failure. Then, of course, the need for dialysis. Once patients get complications that require them to have dialysis in the unit, this complicates their stay. Invasive monitoring, because until the indications for invasive monitoring are gone, you cannot stop the discharge of these patients. And of course, sometimes there are patients who need isolation and they need to be isolated for some time within the intensive care unit. So those will stay longer. The state of the comorbidities. Some patients come with the acute manifestation of comorbidities. Others, they have a single comorbidity. Some have severe single comorbidity, others have multiple. So these comorbidities also influence or affect the length of stay of some of these patients in critical care units. Of course, the state of organ function, multi-organ function automatically is going to prolong your length of stay in the unit. And therefore, the more organs you have failing, the higher the risk of staying longer in the unit. Physical status before admission. As you may know, patients who come to ICU when they have been home, bedridden, others have been on organ support for some time, these are automatically going to stay longer in the units because all the way they've been bedridden, they've been on organ support. So when they come to ICU, they are likely to stay longer because their physical status is already impaired. Yeah, more risk factors, type of admission. You know, some patients who are admitted for palliation, you realize that we admit sometimes patients for palliative critical care. These are patients who are not going to stay for one day unless they die immediately. But if they don't die, they are likely to stay longer in the unit as we provide palliation, because palliation is something that really has no time limit per se. You have to palliate a patient until you achieve the goals you have set. Then, of course, we have the VIP syndrome. You know, we have clients who, when they are admitted to particular units for them, they don't just want to leave, they want to leave at their convenience. And some of these patients may unnecessarily stay in the units for a long time, occupy the beds, but not because they are too sick, but because they're not yet willing to go. Then, of course, we have extremes of age. These are prematures and the very old patients in the ICUs. This VIP abbreviation is one of the new abbreviations for very old intensive care patient. The very old patients and the prematures, they are at a higher risk of a number of complications in the ICU, so they're also likely to stay longer. Severity of illness scores, as you all know, the Apache scores, there are some studies that show that higher Apache scores associated with prolonged length of stay because patients are more sick and therefore they require more time for you to resolve their primary conditions. Of course, delirium is also another risk factor. If patients get delirious, sometimes it becomes hard to discharge a patient who is confused and delirious all over the place. You need to stabilize the state before you send them away. So they tend to prolong their stay. Let's look at something of significance today. We would like to know that was a bit of a preamble to the topic because we need to know, okay, fine. We know that the patients who come to us, some we predict that they maybe stay shorter, others we know they will stay longer, but this is not exactly what happens. Sometimes those who think will stay longer, they stay short. Those who think will stay short, they end up staying longer. So it is important for us generally to know there are some practices that we can perform to ensure that at least the length of stay is minimized for obvious reasons, as we say, because you don't want to have patients to overstay in the unit because of well-known consequences. So for us to be able to overcome these consequences, which include, of course, increase the cost of healthcare, then we have psychosocial impairment for the patients, then we have all these complications which are hospital acquired, including hospital-acquired infection, ICU-associated weaknesses. All these are iatrogenic things that happen within the ICU. And then, of course, we want to improve on the quality of life for the patient. which obviously won't be best in ICU. It has to be somewhere outside ICU. Of course, the family would like to have their patient, and the longer the patient stays in ICU, the more the family gets agitated. So to be able to take away all this, we need to optimize the length of stay. So what are some of the practices? But remember, there's a note here that as you try to attempt reducing the length of stay, make sure it doesn't happen at the expense of quality of life or quality of care. Make sure that you reduce the length of stay, but make sure you do not compromise the quality of patient care and the quality of life. There have been a number of studies to show that continuous sedation for patients, keeping them all the time asleep until you feel comfortable to wake them up, is associated with the prolonged length of stay. So some studies show that when you interrupt sedation or even keep patients on relatively low sedation, keep them as awake as possible, it will improve hearing and also recovery, and therefore may reduce the length of stay. Of course, this you do it when it is necessary. There are patients who can't just keep awake because they are aggressive, they are fighting, and then you are doing so many procedures on them. So make sure that you interrupt the sedation when necessary, and also you take it off whenever you feel it is not needed anymore. But otherwise, continuous sedation, most of deep sedation, is not a very good practice when it comes to length of stay in the unit. So we have ventilation, invasive ventilation. Of course, remember, once you intubate a patient, there's a process of active ventilation, then there's a process of weaning these patients, and then of course there's sometimes ventilator dependency, there's weaning failure completely. So it is been also studied, and some studies show that non-invasive mechanical ventilation has a better outcome in terms of length of stay compared to invasive ventilation. So whenever possible, again, don't compromise patient care. If the patient has indications for invasive mechanical ventilation, you have to give it. If you can avoid invasive mechanical ventilation, maybe stick to NIV and other forms of oxygen delivery, please do it without compromising patient care. That may reduce the length of stay in the intensive care unit. Also, we have early mobilization and physical rehabilitation in the ICU. This has been studied quite extensively. There are quite a number of studies. I chose a few of them here that show that when patients in the ICU are given mobilized early and also given this physical rehabilitation way early in the unit, it improves on their physical function and reduces their ICU and overall hospital length of stay. So we should do, when we admit patients in critical care units, sometimes they're too sick and we concentrate more on their primary insult and we forget that actually mobilization is good. There are different forms of mobilization that can be done for critically ill patients. Some they engage partial parts of the body, others will be full body. And so depending on the status of the patient at any one point in time, you give the appropriate physical rehabilitation to the patient. And we should need to start this early early when the patients are admitted, to make sure that we do not start it late when patients are now struggling with physical pains, body stiffness, then ICU weakness. The earlier the better, and it will improve their quality of life by increasing the physical function, and also makes them more involved in activities. And please remember that when you sedate patients deeply, this part is partially impaired, so you're unable to engage the patient actively into physical rehabilitation. You only be left with the passive physiotherapy, which may not be the case in terms of reducing the length of stay. So get the patients early, mobilized, and also physical rehabilitation. Of course, we have communication. There are some studies that have shown that when you determine clear goals of care between the patient, the healthcare workers, and the family of the patient. You set goals which are more achievable, and these goals tend to, when you set goals that are family oriented, patient oriented, they tend to reduce on the length of stay because the goals are universal to the team. So you need, and for once you set goals like palliation, for example, if you start palliation early in critical care or determine the patient who needs early rehabilitation, then these patients can easily be discharged from the units and maybe taken back home or taken to rehabilitation centers where they can continue getting the long-term care. But if you don't determine these requirements early in life, early in admission with the family and the patient, then you are likely to treat this patient for a long period of time when you're managing things that are not supposed to be managed in the intensive care unit. So it is very important to improve on communication between the patient, the family, and also the healthcare workers, to set goals that are patient-oriented and family-oriented. And this will improve on the length of stay in the unit, because then we can determine what can be done in the ICU and what can be done outside ICU and at home. So that is something quite interesting, and is really a lot of a big focus of recent, that family participation in patient care is very key, because they understand their patient better, and they also understand where they go to patient to hospital. So they should be involved as much as possible in determining the goals of care. Of course, further, there has been some form of protocolized family support interventions, and these are to enhance communication and shared decision making with the family. It was shown to reduce length of stay for critically ill patients without impacting much on mortality. And the key issue here is not really the patient outcome in terms of mortality or survival. It is quality of life. Even if for those little days the patient is going to spend alive, you need them to have a quality life. And therefore, these family support interventions, which made to enhance communication and decision making, which is shared, there's a way they improve the psychosocial understanding of the patient's welfare, and also get the family involved into the patient care, and it gives satisfaction to patients even when they leave the unit. So it kind of bridges the discharge of patients from the unit quite early, because the family will understand the necessary care needed for the patient, both in the unit and at home. So they are more prepared to leave early than when you don't talk to them or when you don't involve them in decision making. So let's pay attention to this. Let's make decisions that are patient-oriented and family-oriented, because at the end of the day, these are the people who are going to continue the long-term care for the patient when they leave the unit. And it will help facilitate early discharge once the family understands what needs to be done. Moving forward, we also have some studies about tele ICU care have also indicated that decision-making authority, during tele ICU care reduce the length of stay during the ICU length of stay, meaning that where you have a decision maker on teleconsultation, you realize that decisions can be easily made and will facilitate discharge, compared to when you make maybe expert consultations, where after getting this consultation, then you have to be the one to make the decision. Sometimes we gather a lot of expert consultations, and either we get confused, or we put all this to the patient, and we end up prolonging the patient's stay because we're trying to intervene using all these consultation advice we have got. But there's been some evidence that when we on tele ICU care, this is where technology has been integrated into patient data aggregation and the alert systems to facilitate diagnosis and patient management. So when you have a decision-making authority on tele ICU care, it becomes easier. It has improved on the length of stay because someone else is able to make a decision even when they are not with the patient, but for the patient. So you can read more about this tele ICU care. It is something that we can't avoid right now. Telemedicine is all over the world. It is growing, and some of these you need a person who with authority to be able to be on the other end of of telecommunication to ensure that decisions are made. Otherwise, if you have non-decision makers on the other end, then they are going to be dragging over decision making and so on. So if you have a decision making authority during tele ICU care, it was shown to reduce on the length of stay. Basically, it's an issue of decision making. The earlier the decisions are made, the better. Now, there has been some communication, some studies on vitamin C supplementation for ICU patients. And this particular study, which was published in the Nutrients 2019, showed a benefit in terms of reduction in length of stay of 8%. And with such a p-value, but basically what they did, they administered 1 to 3 grams per day of vitamin C to patients. And when they analyzed the data at the end of the day, they found that patients who received the 1 to 3 grams per day of vitamin C had a reduction in their ICU length of stay of about 8.6%. And their discussion or conclusion or advice would be that if there is even a small percentage that you can improve on the length of stay, why not do it if it has no harm? And yes, indeed, if administering this drug and any other drug provides an advantage without causing harm to the patients, why not take it? Because we were looking for the smallest changes that can give us a very big impact, like reducing the length of stay in the intensive care unit. Of course, we also have nocturnal tele ICU interventions. This study, when they looked at in the ICUs that this was a meta-analysis. They looked at ICUs that do a lot of nocturnal tele ICU interventions, and they realized that for ICUs which had big numbers of admissions during this period, they had an improvement in the length of stay of the patients who were admitted during the nocturnal tele ICU interventions. Basically, this means that patients admitted on during night, and the interventions are initiated, management initiated on tele ICU interactions. They had an improved length of stay because decisions could be made in the night very fast, because the appropriate consultants are available to give the necessary advice and intervention for patient care immediately on admission in the night. So they realized that the initiation of this appropriate treatment through the tele ICU interventions significantly dropped the length of stay. So as we look more into that study, we realize that there was an advantage that you should have the ability to access appropriate human resource at night via tele ICU interactions and interventions. So that is something to explore, mostly in our setting where we are not yet much into tele interactions, but as you know, AAU has started this kind of thing with anesthesia consultations and ICU consultations over the phone. This is exactly the way to go, because experts are scattered all over the country, and you should not be denied their expertise just because they are not physically available. You should be able to get the same information that you need from them even when they are away. This is the purpose of tele interventions and communication. Of course, RAS, some of you who know this sedation assessment score, it is a score that we use to gauge the level of sedation for patients in ICU, measure those who you have put on sedatives. In this study conducted and published in Applied Nursing Research in this year, they found that the nursing implementation of the RAS limits over sedation for ventilated mechanical for ventilated patients reduced the number of mechanical ventilation days in the ICU and also reduced the length of stay in the ICU. Basically meaning that a mandated RAS, where patients must be assessed using a RAS to determine what the level of sedation we should give to them, compared it to blind sedation, where you just give patients sedation and looking at them and imagine that they are now sedated. That did not produce very good effects. But when they did mandated RAS, as per the protocol the nurses had, they realized that sticking to the RAS and following it closely was associated with a reduction in the number of mechanical ventilation days and also the length of stay. So meaning it would be very nice for you to objectively sedate your patients by looking at the degree of sedation and targeting what sedation levels you want, other than blind sedation, where patients will go all the way too deep to RAS -3, -4 without your knowledge. You know, when you need to wake up such patients, you need more time than if the patient was on a targeted RAS of -1. So it is important that we consider this research, look into it, and see if it is locally applicable. And if it is, then you advise the team that you are dealing with to practice such things, because they improve quality of life by reducing on the number of mechanical ventilation days and also ICU length of stay. Next, I will look at the discharge management process. As you all know, this is something that is an international problem. But coming back home, where you have limited hospital beds, it becomes very, and remember, we don't have rehabilitation centers, mostly in Africa, for patients who have been in ICU for some time. Usually they are discharged straight to the ward, and the wards usually are very scared of receiving patients from ICU. So what usually happens is that you'll have a number of patients who overstay in the ICU because either the ward has no space, that means there was no bed, or the ward has the bed, but the team there is not very comfortable managing a patient from ICU. So they would like you to give them a patient when the patient is almost purely a wardy patient. Now, this is a very big challenge, and it is something that we need to fight more so in our setting where we have very few ICU beds, because we need to free the ICU beds for the other patients. But at the same time, if the ward is not comfortable taking on these patients, we risk compromising patient care. So we are in a kind of a dilemma, but the best way to go about it is ensure that the ward teams are well equipped and also empowered to manage your ICU discharges. Because remember, ICU discharges are going to be either those who are purely cured or those who have some kind of longer term disability that is going to be on, maybe they're even ventilator dependent, others are going to be dialysis dependent, but they have to be discharged to the ward. Now, the ward team has to be empowered to handle such patients and also equipped to handle such patients, so that we don't keep patients in the ICU because they are ventilator dependent. No, we should be able to let the patients go to the ward on simple ventilation, because it is now their new normal and they have to maintain it, and we can't maintain it in the ICU. It has to be maintained on the ward and later at home. So discharge management process is a very complex process when it comes to discharge of ICU patients. And in some centers, we realize they will tell you when a patient is discharged from ICU, at least for the first night, keep them with a one-on-one nursing. Because all this is because of a fear of handling an ICU patient on the ward, although they are no longer fitting the category of ICU patients. People are always afraid that maybe they may deteriorate very fast. All these patients may die. Also, there's that fear, and it's understandable. So you need to train the teams on the ward to accept the new normals in some of these patients, and also to know that the ICU team is readily available for consultation in case of anything, so that you empower them to receive these patients peacefully. That will help reduce on ICU length of stay. But the main, whatever, at least what has been documented as the main cause of delayed discharge from the ICU to the ward is majorly bed space on the ward. That said, I have some take-home message for us. The information about length of stay is really much. What I've discussed here are some of the few factors that have been studied, but there are also a lot of anecdotal evidence where it exists in your local areas, in different whatever setups, how you can optimize patient length of stay. Of course, as a team that manages critical ill patients, you also need to remember to have clear guidelines on when to discharge patients so that you don't keep them in the unit when they don't have to be there. You have to have very clear guidelines on where these patients should go. All these processes, as much as they may not be documented, they help improve on the length of stay. We need to shorten it as much as possible so that we cut on the cost of healthcare, reduce on the family agitation caused by very many things, that is hospital stay and money and psychosocial impairment, psychological breakdown. We also need to remember that patients suffer complications in the hospital, minimize complications so that you can reduce on their length of stay. If patients get more medical errors in the ICU, patients get more complications in the ICU, patients have so many interventions done in ICU, make sure they are all justified, because each intervention you institute on a patient somehow is going to prolong your length of stay. You put more catheters in the patient, you want to do more procedures in the patient and they're not being done promptly, you are pushing time for the patient to stay in the unit. So make sure that you minimize all these little things that may increase the length of stay of these patients. Family conferences should be done so that the families are well informed about what's going on, because patients also, their families have to be comfortable. Sometimes the family is uncomfortable moving their patient from ICU to another ward, and that alone can prolong your ICU stay because the family is refusing, is saying we are not ready to go out of ICU. So communicate to them effectively so that you can discharge these patients as early as possible. Of course, where need be consultation, please consult the people who you should consult. It is very important to know that at the moment, we have no universal definition of increased length of stay, but this can be defined according to your unit, with the type of patients that you receive. Are they surgical? Are they medical? Are they patients with chronic diseases? Are they patients with acute diseases? You define the length of stay according to the nature of patients that you receive. Then it is important for you to know that the other things that affect patients' length of stay, okay, which may be patient factors, that is severity of illness, number of illnesses, then you have duration of the illness, then interventions required. Of course, we also have economical issues where we know payments, sometimes you have to have had, sometimes patients are ready to go, but the hospital won't let them go because they have not yet paid. Of course, that is also increasing length of stay in the hospital and of course in ICU. So it is important to have good financial management processes to enable patients to leave units, whether they have paid or not. Then we have, of course, the hospital factors. If the hospital is very small, has a very big ICU with very few general wards, then you will have a lot of ICU patients who need to go to the ward, but the ward is full. So these are hospital factors. Hospitals need to improve infrastructure to ensure that the ICU beds are proportional to the hospital general beds. Of course, then staffing factors. Make sure you have appropriate staff in terms of numbers, expertise, and of course allocation. To all these factors, they may not be well studied and documented, but they have a contribution. Then, of course, multimodal approach to the required is required to reduce length of stay. Don't look at one thing and say, oh yeah, when we talk to the families, then the length of stay will be reduced. If we don't do many procedures, the length of stay will be reduced. No, you need to put all these models together, and then you will have something substantive for you to follow and reduce the length of stay. Otherwise, if you look at each approach on its own. No, it doesn't work like that. So make sure that you handle the different aspects of the patient care in line with the trying to reduce the length of stay. Handle them together. Now, to disciplinary approach, consult colleagues whenever possible. The earlier, the better. Don't play a hero. No, get advice from colleagues as much as possible and as at the earliest opportunity. If it is physical, fine. If it is not physical, telemedicine. Contact them. Contact your colleagues wherever they are all over the world and get assistance in terms of decision-making, advice, and so on. It will improve on patient's care and probably reduce on length of stay. Early interventions and prevention of severe disease. Remember, if you intervene early, you are likely to prevent complications. This is very important to avoid the unnecessary delays in intervening, because when we do, patients score, severity of illness scores are going to go high. And when they go high, trust me, more interventions are needed, more time is needed. Likely, the length of stay is going to be bigger. And of course, lastly, prevent sepsis if you can. Prevent sepsis. IPCs should be observed everywhere, not just in ICU, but in hospitals and probably outside of hospitals. IPCs, infection prevention and control processes must be implemented. Avoid mechanical ventilation, invasive if you can, and maybe stick to non-invasive and other modes of oxygen delivery and respiratory support. If you can, whenever you can, remember to do all this without compromising patients' quality of care. ARDS is a problem. If you can prevent this ARDS from hospital-acquired infections and any other causes of ARDS, this will be very great. It will reduce on your time. And also delirium, try to avoid patients getting delirium. I mean, not delirium is underdiagnosed, it's underassessed, but try as much as possible to ensure that you actively look out for delirium and prevent it before it happens, and minimize sedation of these patients. Keep them at a sedation level that is acceptable so that it makes it easy for you to win sedation when time comes. All these put together and many more that I have not mentioned here. There's a lot more information about what you can do to reduce the length of stay for patients in the ICUs and in the hospital at large. Please employ them, keep looking out for them. There's more evidence coming up every day. Have it, share it with your colleagues so that you can together and collectively share this information and intervene with the goal of reducing the length of stay. Thank you very much for listening to me. My time is up, and the additions are welcome. Questions, clarifications are all welcome as we share this topic for the benefit of our patients and our units. Thank you very much. Questions are welcome.